In this PowerPoint, we're going to go over the different types of sleep-disordered breathing. This is covered in Chapter 16 of your Fundamentals of Sleep Technology textbook. To begin, these are just some of the abbreviations for different sleep-disordered breathing. I'm going to go ahead and define these. You can also find them in your textbook, though. Obstructive sleep apnea, also called OSA, is a repetitive pattern of upper airway obstruction that occurs during sleep and is associated with sleep fragmentation and or oxygen desaturation. Now we're talking about your upper airway. This would be the back of your throat above your vocal cords. When we talk about oxygen desaturation, that is not a requirement for an obstructive sleep apneic event to occur, but it is oftentimes does occur with them. The clinical syndrome has variously been called OSA, the OSAS, and the obstructive sleep apnea hypopnea syndrome. So these are all interchangeable terms. Partial obstruction of the airway, which is also called a hypopnea, is frequently seen in the syndrome, and so the term OSAHS is used interchangeably with OSA. A milder upper airway obstruction, which is called respiratory effort-related arousal, or also called ARERA, also causes fragmented sleep, but it has minimal decreases in upper airway resistance. It does cause the patient to awake and feel unrefreshed during the day. Upper airway resistance syndrome, or UARS, is the mildest form of obstruction, and it can also cause clinical symptoms. We tend to see females have UARS more than having OSA. In contrast, men typically have more OSA and less upper airway resistance syndrome. So men tend to have more severe upper airway obstructions as compared to women. It doesn't mean women don't have it as either, it's just theirs doesn't tend to be as severe. Sleep patterns of abnormal breathing, snoring, RERAs, hypopneas, and apneas, all combined are referred to as sleep-disordered breathing. So sleep-disordered breathing is a very general term. All the other terms are more specific. Let's go on to our next slide. Now I'd like to take a look at some of the factors that contribute to OSA during sleep. If you'll take a look at the picture, we're going to identify the numbered areas on your picture. Number one is your maxilla, and the opening to the nose is just above this. So your nose is just above your maxilla. The other structures of the airway include number 2, this is your mandible. Number 3 is your hard palate, that's what your tongue can push up on in your mouth. Number 4 is your soft palate. Again, your tongue may push up on that in your mouth, but it's way, way back by your uvula. Number 5 is your uvula, and that's the little dangly thing in the back of your throat. The body of your tongue is called the genioglossus muscle, and this is a high contributor to sleep apnea. Pharyngeal collapse in apneic patients typically occurs somewhere between number 7, which is the choana, and number 8, the epiglottis. Usually behind the uvula and soft palate, behind the tongue, or some combination of these sites is where the pharyngeal area collapses, obstructing the upper airway. So again, it's all above the vocal cords. In humans, the hyoid bone, which is number 9, is not firmly attached to any bony structures. It just floats in your neck there. And it is allows for us to have a wide range of vocalizations during speech. But because of this, it increases the dependency on the upper airway muscles to keep the airway open because you don't have any bone structures there holding the airway open. So, along with your anatomy, parts of your anatomy that can contribute to sleep apnea is if any of these structures are abnormally large. For example, if you have an abnormally large uvula, that could contribute to snoring and also upper airway obstruction. So along with the actual structures of these being abnormally large, your weight distribution, people who have more weight in their upper neck area, again, that's going to put more weight on the airway, once the patient falls asleep and loses their muscle tone. Also, the craniofacial structures. For example, if someone has a jaw that is receded back towards the back of their airway, sometimes these people look like they have very small chins when in reality their entire jaw structure is just pushed back further in their airway. Those can all contribute to upper airway obstruction. Another term, macroglossia, that's where someone has an enlarged tongue. That can also cause it. The posture of a patient when they're sleeping, gravitation has a huge effect on patient's development of sleep apnea, especially if they also have excessive body mass in the upper airway. As the patient lays flat, there's more likely for the gravitational pull to cause that airway to collapse. Whereas if they lay on their side, there is less body mass compressing on the airway. Or if they're sitting in a reclined position as opposed to being flat, then there's less gravitational effect. REM sleep, we've talked about this a little bit before. In this stage of sleep, the body is paralyzed, so you lose all muscles, even your dilator muscles. So this contributes to an increase of sleep apnea when a patient is in REM sleep. Let's go to our next slide. So here is a visualization of the different types of sleep disordered breathing. All types of sleep disordered breathing, in order for it to be scored or diagnosed, each event must last a minimum of 10 seconds. Now, this is similar to what you're going to see on your sleep study tracing. The red line on this one is going to represent airflow, so that's being monitored at the area of the nose and mouth. And then blue is going to be your effort, and that is monitored at the area of your chest or thorax area and your abdomen with your respiratory belts. So if you notice with central apnea, there is no effort, and if there is no effort, there is also no airflow. So with central apnea, the patient does not make an effort to breathe for 10 seconds or longer. There is an absence of both effort and airflow. Going down, we're going to take a look at your obstructive apnea. Here you see a patient who has effort. They're trying to breathe, and we can tell this from their respiratory muscles in their thorax and abdomen, but there's no airflow coming out the nose or mouth. So somewhere between their chest and abdomen and their nose and mouth, the air is being blocked. And again, this must last a minimum of 10 seconds. Going over to the right side of your picture, we'll look at the hypopnea. Now this one's a little deceiving. It shows that there's no respiratory effort with an hypopnea, and that is impossible. Really what it is there is effort, but it maybe isn't as great as with an obstructive apnea, and the overall result is a decrease in airflow by 30% or more. A hypopnea can only be scored if there is a correlating 3% oxygen desaturation or a correlating 4% oxygen desaturation. It depends on which rules you're using for that to be valid. And then lastly, there is a RERA. This one's a little hard to tell, but with a RERA, what happens is there is a reduce in airflow, but you see an increase in respiratory effort. So there's some airway resistance going on in the airway, so the patient starts to breathe harder and deeper muscle-wise, but the actual measured airflow is less than normal. A RERA has to cause an arousal, but it does not need to have an oxygen desaturation. Let's go on to our next slide. This slide shows information from a study which examined the prevalence of sleep apnea in 30 to 60-year-olds population. So there was a random sample of 602 men and women, and they were studied in a sleep lab using the standard polysomnography. They used a cutoff of an AHI, that's an apnea-hypopnea index, of greater than 5 per hour. There was a high prevalence of sleep-disordered breathing in both men and women. An elevated apnea-hypopnea index, or AHI, was found in 24% of the men and 9% of the women. When the AHI is combined with symptoms of sleep apnea, a minimum prevalence of sleep apnea syndrome was determined to be 4% in men and 2% in women. For comparison, the prevalence of asthma, another common disorder, is 4.5% of the United States population. So they're just showing how sleep apnea is a fairly common disorder. And when you look at AHI alone, you get a percent of 24% in men and 9% of women. But then when you consider it along with the symptoms of sleep apnea, which would be daytime sleepiness, hypertension, difficulty concentrating, etc., then they found it to be 4% in men and 2% in women. So just a little information for you. Let's go on to our next slide. Let's talk a little bit about the risk factors of sleep apnea. The most significant independent risk factor for sleep apnea is obesity. The risk for OSA increases as the BMI increases. Weight reduction can lower the apnea-hypopnea index, or AHI. Weight loss can, in some situations, be curative for sleep apnea, but that is not always the case. Obesity is the most powerful risk factor for OSA, and it is also the main reversible risk factor. Potentially, other risk factors that could be modifiable, meaning there's things that the person maybe is doing that's causing them some sleep apnea or making it worse, that they could change, would be alcohol use, smoking, nasal congestion, and estrogen depletion in menopause. The only risk intervention strategy supported with adequate evidence is weight loss and CPAP. Talking a little bit about gender, males have a 2-to-1 to 3-to-1 prevalence over females in the population. They believe part of this is due to hormones and the fat distribution. They predispose males towards a more collapsible airway. Males have an 8-to-1 prevalence over females in the sleep center. They believe this is because it's more readily identified by the primary care doctors, and they often are more times prompted by their female partners to seek treatment. So women tend to not go to the physician for sleep apnea complaints as much as men do. The gender difference in prevalence starts to equalize when women start to enter menopause. So about that time, you see more women going to the sleep physician and seeking help with their sleep disordered breathing. Age, there is a linear relationship between age and risk of sleep apnea. It starts in middle age and plateaus about age 35. So what this is saying is that around the 30s, 40s area is when people start to develop sleep apnea. But by the age of about 65, if they haven't been diagnosed at that time, they're not likely to develop it after that age. They do see a marked increase in OSA in women after menopause. In old age, the apnea-hypopnea index is not as strongly correlated with obesity, excessive daytime sleepiness, cognitive dysfunction, or hypertension. So as they get older, again, if they haven't been diagnosed with sleep apnea, they don't tend to develop it. Snoring tends to subside in old age. This could be because of the hearing loss, so no one is there to complain about it, or it could be to the fact that as people get older, they tend to develop what's called central sleep apnea, and that's where they don't even attempt to breathe. So no longer are they obstructing, their body isn't even attempting to take that breath. And then we definitely have a family contribution here. There's a direct increase in risk of OSA for each diagnosed family member. So this means if your father had sleep apnea, you're more likely to have sleep apnea. If your grandfather has sleep apnea, you're more likely to have sleep apnea. This is a combination of genetic and environmental factors. Obesity in itself is an independent risk factor, but it can also be affected by family lifestyles and dietary factors as well. We talked a little bit about the craniofacial features. That means like if you have the recessed jaw or the large tongue. Race does play a factor as well. And then there's also some other contributions too. Let's go on to our next slide. Cardiovascular disease and OSA. They have found definite connections between all of these factors and sleep apnea. Let's start with congestive heart failure, which isn't really listed on here, but it kind of goes along with your coronary artery disease. Many patients with congestive heart failure have obstructive apnea as well as central apneas and hypopneas. In 81 male patients with congestive heart failure, they found 40% had central sleep apneas and 11% had obstructive sleep apneas. The patients who had obstructive sleep apneas were typically heavier on average than the patients with central sleep apnea. So they do know with heart failure, patients do develop central sleep apnea. There is also an increase of heart failure with obstructive sleep apnea. The odds ratio of 2.38. There's a high frequency of atrial fibrillation and ventricle arrhythmias in patients with both sleep apnea and congestive heart failure. With coronary artery disease, we have found that there's an increased risk for myocardial infarction, or an MI, this is also called a heart attack, in patients with obstructive sleep apnea. It's 4 times greater than those without sleep apnea. Sleep apnea patients may be at higher risk for subsequent cardiovascular events after a heart attack, which they believe is due to hypoxemia. Stroke has a strong correlation with sleep apnea. They have a high incidence of OSA in patients who have had a stroke. There is a positive relationship between the history of stroke and higher apnea-hypopnea index. They believe the stroke risk is 2.5 higher in patients who have sleep apnea as compared to those who do not have sleep apnea. Sudden cardiac death. They have found that there are 2.5 times of risk of sudden cardiac death between the hours of 12 a.m. and 6 a.m. for patients who have known sleep apnea. Increased nocturnal arrhythmias could be a contributing factor. This tends to occur between 6 to 11 a.m. or generally after waking up. In sleep apnea patient, it tends to occur while they're sleeping. Let's go on to our next slide and we'll take a look at hypertension. In this representation of those with hypertension and the relationship to an increase in apnea-hypopnea index, we see the patients listed on the vertical column and the different degrees of AHI on the horizontal column. So you see at 40% of patients who have hypertension, they have an AHI of 1.5 or greater. When we get to about 50%, we see their AHI of somewhere between 1.5 to 4.9. As we get to 60% of patients with hypertension, we see their AHI of 5 to 14.9. So that means they're stopping breathing 5 times per hour during sleep, or up to 14.9 times per hour during sleep. And then we see as the AHI continues to rise, 15 to 29.9%. Again, that's about 60%. And then when the AHI gets above 30, we're rising to about 70% of those patients with hypertension also have an AHI of greater than 30. So there's a direct correlation between the development of AHI and an increase in, or the development of hypertension and the increase in their AHI. Let's go to the next slide. Here's the types of arrhythmias that are common in patients with sleep apnea. Again, they're not for sure why all of these occur, but these are why they think. They believe hypoxemia causes AV block type 2, hypercapnia causes third degree block, acute increase in blood pressure causes the Brady tachycardia pattern, an increase in sympathetic activation causes ventricular ectopy, vagal response to obstructed breathing causes atrial fibrillation, and rapid changes in the intrathoracic pressure cause sinus pauses of 3 to 12 seconds. I will never ask you to identify each of these. The main thing is know that hypoxemia is a major contributor to arrhythmias in patients with sleep apnea. Let's go to our next slide. Here's just a graphic or a picture of what the different arrhythmias look like on your EKG recording. This is not going to be our focus in this course. We will focus more on that when you get further into your polysomnography 1 course. Let's go to the next slide. Here is just a representation of sudden cardiac death. You see the graph in purple. Those are patients who have sleep apnea. The one in orange are the people who do not have sleep apnea, and then green is just general population, so the combination of the two. Notice from midnight to 6 a.m., there are 45% of sudden cardiac deaths occur in sleep apnea patients during this time. Compared to those without sleep apnea, only about 20% of those people have sudden cardiac death at this time. In comparison, from 6 a.m. to noon, patients without sleep apnea, that's when they most commonly have sudden cardiac death. As compared to those with sleep apnea, they only have about 20%. Noon to 6 p.m., so in the afternoon, again, those without sleep apnea, it's much higher. And then again at nighttime when they're sleeping, it's much higher in the group who has sleep apnea. So this just proves that those who have sleep apnea tend to have more sudden cardiac deaths when they're sleeping. Let's go to the next slide. Endocrine dysfunction. Let's start with diabetes at the top of the page. OSA and diabetes are reciprocal independent influences. The repetitive cortical arousal and hypoxemia from sleep apnea cause insulin sensitivity to worsen and glucose tolerance to build up. There's an increased risk of sleep apnea in patients with diabetes. 1 in 4 patients diagnosed with diabetes with autonomic neuropathy also have OSA. They believe the neuropathy may contribute to the collapsibility of the upper airway. So they don't know which one comes first, but they know that if you have diabetes, you're at a greater risk for sleep apnea, and if you have sleep apnea, you're at a greater risk for diabetes because they both influence each other. Again, this is kind of that chicken and egg situation. They don't know which one comes first, and with some patients, one may come first, and in other patients, the other may come first, but they know there is a direct correlation. Metabolic syndrome, also known as Syndrome X, this is a cluster of health concerns. The cluster includes obesity, high cholesterol, hypertension, and insulin resistance. Syndrome X has become so closely associated with sleep apnea that the term Syndrome Z has been proposed for patients who also are known to have all of these health concerns with sleep apnea. Hypothyroidism, this is a reduced production of the thyroid hormone. It increases sleep apnea due to associated weight gain, soft tissue, especially the tongue, and facial swelling that occur, and then also myopathy, which is a weakening of their muscles. They lose muscle tone. Let's go on to our next slide. All right, clinical evaluation. We want to review the medical history. Things that would include that would be the demographics, any of their comorbidities. This would be if they have obesity, endocrine disorders, cardiac dysfunction, any special needs or medication. Then they're going to want to review their sleep habits and problems. Have they had witness apnea? Does someone complain of them snoring? Do they wake up gasping and choking at night? What's their total amount of sleep? Is their sleep fragmented? Do they have problems maintaining their sleep? Do they have insomnia, and what's their sleep environment like? Next, they want to evaluate their daytime symptoms. Do they have nocturia? This is frequent need to urinate. Do they have morning headaches? Do they have a decrease in concentration, memory loss, a decrease in libido? Are they irritable? Do they have an increase in motor vehicle accidents? Are they drowsy during the day or have problems falling asleep? And next, they also want to do a physical exam, review all of their body symptoms, examine the upper airway, evaluate craniofacial structures, do a Mallampati scale, measure their BMI and their neck size. Let's go on. This is an example of a hypnogram. So this is a graphic representation of what happens during a patient's sleep. It's the display of the whole recording of all the polysomnographic channels together to see all on one page how all of the physiological changes relate. So if you start at the very top line, this is their oxygen saturation, and you see at the beginning of the night there's not a lot of jagged lines, but as the night goes on they get more and more jagged. This means they're having more desaturations and their oxygen level is dropping lower and lower as the night goes on. The next one is your heart rate. Again, you see very little heart rate changes to begin with because the line is nearly flat, but as their oxygen desaturations increase, so does the heart rate changes, and that you see it by the change in those lines. Next, you have your central apnea, which in this patient we're not seeing any. Their obstructive apnea, these are in red. Mixed apnea, you see just a few in black towards the end of the night, and then hypopneas you see in pink. So you notice at the beginning of the night there's nothing really happening, and then a little further on you see some pink and red, so that's apneic events and hypopneic events going on. And then later towards the end of the night, probably when the patient's in REM, that's when you're seeing the majority of the obstructive apneas, and you're seeing that correlates well with those oxygen desaturations. Next is a graphical representation of the stage of sleep they're in, and we're not going to worry too much about this now, but by how many different lines you're seeing going up and down here, that's how many times this patient changed stages of sleep. And the more times you change stage of sleep, the more fragmented your sleep is, so you're not getting good rest. The next line down on the brown, that's showing how many arousals they had, and you can see throughout the night this patient is having several arousals, which correlate well with the obstructive apneas and the hypopneas. This patient has a position training or position marker here showing the different body positions. We don't really have a key to know what position they're in for this one. Next you have IPAP and EPAP. That would be if they're on CPAP or BiPAP, and this patient is not on either at this point. Next you see your snore mic, and it's showing how much snoring they're doing. And then the next one is your desaturation. It identifies how often the patient had a desaturation. Next is your bradycardic events, and you see that happen once later in the night. And then your last line there is your tachycardic events, and you see a few throughout the night. So this again is called a hypnogram. It allows you to compare what's happening in different areas of our recording equipment throughout the night. Let's go on to our next slide. Okay, let's talk about treatment options. There are a variety of treatment options that we can use with patients. We can do behavior management, we can do PAP therapy, we can do oral appliances, and we can do surgical management. For behavioral management, the basics of that include educating the patient about sleep apnea's causes and the consequences of sleep apnea if they don't get it treated, as well as their treatment options. This should also include some discussion about weight loss, avoiding sedatives, alcohol, smoking, positional therapy, meaning how to help train the patient to not sleep on their back, because we know sleep apnea is always worse when a patient's on their back. This includes helping them realize that treating their allergies and nasal congestion could improve their breathing while they sleep. We talked a little bit about this earlier. Weight loss all in itself can be curative for some patients, not all, but some. Weight loss after bariatric surgery has shown to lower the AHI, but not cure it. Treating sleep apnea can sometimes give patients the energy and vitality to begin a really good weight loss program. So maybe we start with some CPAP therapy, they sleep better, then they have more energy, and they're more able to lose the weight effectively, and they may get off the CPAP eventually. Again, positional therapy, this is helping train the patient so they don't sleep on their back. There's been a study that showed that 55.8% of patients with sleep apnea had twice as many respiratory events when they're on their back compared to when they're on their side. So there are some patients that only have apneic events on their back, and then others, we just know that it's going to be worse on their back. And then we have PAP therapy, and this is the first line treatment for mild to severe sleep apnea. The only limitation to this is the patient's ability to tolerate it. Effectiveness of this therapy is based on the patient's adherence to therapy, meaning they put it on every single night and they wear it. But it is 98% effective in most patients as long as they wear it. Let's go on to our next slide where we take a look at some oral appliances. Oral appliances, there are a variety of oral appliances out there, and they are creating more as we speak. These are indicated for the mild to moderate OSA patients. There's a success rate of about 52%. Dentists and orthodontists can specialize in sleep, and they will evaluate the bite, the dental structure, and the jaw. Then they will follow up with the patient for side effects and response to therapy, and then they can adjust it if needed. They will titrate these in the sleep lab sometimes, and it's by adjusting the jaw or tongue forward with these different devices. Typically doesn't have any side effects, and they only wear these devices while they sleep. Let's go on to the next slide. Nasal expiratory resistance devices. I've described these in another PowerPoint. I didn't really have a picture for you at the time, but I described them as things that look like Band-Aids that you put over your nostrils. And you can see this patient's here. Again, this is indicated for mild to moderate OSA. These nasal valves build negative pressure to maintain patency of the airway while the patient exhales. The response to this is variable, so a sleep study may be necessary to see if it's effective, but basically they use it based on patient symptoms. Again, if a patient can tolerate it, that's kind of where the problems lie. And then follow-up is required to monitor the patient's symptoms and to make sure they're wearing it. Let's go on to our next slide. There are different surgical interventions that can be done. This can be used as a first-line treatment, but typically it's reserved for patients with very mild sleep apnea. The main goal of each of these is to increase the size of the upper airway to increase the patency of the airway. Patients need to be educated about the risks. This is a more painful option in the short term, and the success rates vary quite a bit. So definitely something to talk about with your physician. Let's go on to the next slide. With nasal reconstruction, they can do this with deviated septums. They can correct if there's a nasal valve collapse, and they can do this radiofrequency treatment of the turbinates where they kind of like grind them down. The success rate for eliminating OSA with these procedures is fairly low, but they can be helpful for patients who are using PAP, but they're not comfortable with the PAP because of obstruction of their nasal passageways. Let's go on to our next slide. Pharyngeal surgery. You can look here, the picture before and after. You see the picture before, you see the tonsils, you see the uvula there, and in the after picture, you see the tonsils are gone and the uvula is gone. So adenotonsillectomy is the first line of therapy for sleep apnea in children when they're enlarged. Not for adults. Adults, our first line is CPAP, so that's a difference between pediatrics and adults right there. The UPP is the most common adult surgery, and this is where they take out the uvula, the tonsils, and part of the soft palate. The success rates are variable. They say about 50% of these are successful. My husband had this done, and it was not successful. Radiofrequency ablation reduces the size of the soft tissue, and this again is indicated for mild to moderate sleep apnea. It can lower the AHI and improve sleepiness and quality of life if it's effective, which it's not always effective. So let's go to our next slide. Maxillomandibular advancement, MMA. This is a successful surgical intervention for sleep apnea. It reduces the AHI of 87% with a mean post-operative AHI of 7.7. So it drops their AHI considerably if it's done. This is a major reconstructive surgery though. Here they're cutting and advancing the upper and lower jaw bones to enlarge the posterior airways, and they can enlarge it up to 12 millimeters. This can be considered for patients with reduced airway diameter due to a small or receding jaw. So someone with micrognathia or retrognathia, this would be the best option if they didn't want to wear CPAP. But again, this is major reconstructive surgery. This is where they're going to have to wire your jaw shut for a while. Let's go on to the next slide. Tracheostomy or tracheotomy. This was originally the primary treatment for sleep apnea before the invention of CPAP. It is still 100% effective. So if you have someone who just can't treat, this can treat it. It's indicated when other options have failed, or when treatment is refused, or if it's deemed necessary due to a clinical urgency. I do know a physician in town who has a tracheostomy because he couldn't get used to CPAP, and so he keeps it capped during the day and just opens it at night when he goes to sleep. So for some people, that might be what they prefer. Not my first choice myself. Let's go on to the next slide. Okay, so just to summarize what this PowerPoint reviewed, it discussed OSA as a common disorder. We talked about different terms that all kind of mean the same thing. We discussed a little bit about the diagnosis and treatment. It requires a team of trained sleep professionals. It's not just the general care doc. You need a sleep specialist. You're going to need a sleep tech. Some cases you might need a surgeon or a dentist or orthodontist. So it can include a wide variety of people. Treatment does reduce a patient's risk of death, major cardiovascular morbidity, cerebrovascular events, that would be your strokes. It decreases motor vehicle accidents and improves quality of life. Sleep technologists often get a great job of satisfaction from seeing sleep apnea patients improve from their testing and treatment interventions.